Well, welcome to the Disruptive Dental Science Podcast. And if you're anything like me, you love to learn, you love to try and enhance your own clinical skills. And to be able to do so, I love asking questions. And I did that with Dr. Celin Arce. He's a prosthodontist. And I wanted to ask him how he believes the field of conservative dentistry applies to prosthodontics and how he treats his patients. I also asked him as to what he uses in his own practice, what materials he uses, what equipment he uses, what steps and protocols he has to enhance his ability to treat his patients as well. So if you're anything like I am and you want to learn a little bit more and you want to ask some questions, by all means, let's do so together. So let's jump in. Well, hello, everyone. Welcome back to another episode of Disruptive Dental Sciences. I am once again your host, Dr. Ashton Prince. I am one of the clinical ambassadors here at Dental Advisor, and I'm honored to be joined today by for me personally, a friend that I have just made recently, Dr. Celin Arce, based out of Kentucky. Is that correct, Celin?
That's correct. Actually, in Kentucky.
So it explains the horse that he's got behind him as well here. So if you wouldn't mind, introduce yourself just a little bit for those that are listening in, for those that don't know who you are.
Perfect. Thank you for having me. I'm Celin Arce. I'm a prosthodontist. I'm originally from Costa Rica, but I did my residency program at University of Alabama. And now I'm working in Lexington, Kentucky, and also with my wife that is also a periodontist. So we have a prosperial type of team. And yeah, so that's the very short summary.
With working with your wife, but we may get into that later, but we may not, whatever it be. Now, you work out of the University of Kentucky as well, is that correct?
That one's it, yes.
Okay, beautiful. Now, I've been told that prosthodontists, they're the magicians in dentistry. All the amazing clinicians that I know all have a prosthodontic backing. I don't know if it's just because you spend that much more time on things that the rest of us clinicians just rush through, but some of the most amazing, beautiful work I've ever seen, yours included, I might add, is coming from those that are prosthodontists. So from those that are the magic workers, tell me, what are the things that currently in the field of dentistry you're most passionate about right now, or the things that really get you on fire?
For me, I had almost like a little change in the way that I'm doing things. So my pros program was my program director and a little bit in the older side, like it was trained in the 80s. So my pros program was very traditional type of pros, like hairfare preparations, the taper, occlusal convergence, and the pins for buildups and all that type of stuff.
Sure.
So I was very happy with the training that I got in residency, but at the same time, since I'm from Costa Rica, I get a lot of influence from dentists from Brazil and Latin America and Europe. So definitely I was exposed to a lot more of the adhesive dentistry in terms of the preparations, that we can do a lot more conservative preparations, a lot more conservative designs. Also with all ceramic restorations that we can bond, we can be a lot more conservative. So right now, I think, and now with the digital technologies, I think we can combine those two very well to be conservative and using digital technologies. So right now, I think I'm very passionate about I still do full my rehabs type of restorations, but now it's not so much of the traditional, just going to hold and prep 26 rounds at the same time. Now I'm trying to do more conservative designs and do adhesive dentistry with digital technology, combine all those and be a lot more conservative. Also, I'm very passionate about implants, especially implants in the aesthetic zone, and try to make those implants as imperceptible as possible. So I think those are probably the two main things that I'm very passionate about in dentistry right now.
Beautiful. So just for those that are listening and for anybody that's got the curiosity to it, we as clinicians use all the time the phrasing traditional and conservative. What in your mind makes you say, I'm being conservative here, but I'm more traditional with that? What's the difference between being traditional and being conservative to you?
So I think the old concepts from Crown and Bridge type of preparations, like Goodacre, he published that like early 70s, always 1.5, 2 millimeter margins, 360-degree preparations,
sure,
very parallel preps in order to get the resistant retention form. Build-ups were done with retention pins with amalgams. So for me, that's more like the traditional type of preparations.
Okay.
Nowadays, we're trying to do what we call defect-oriented preparation. So that means that depending on each patient, the type of defect that they present with. sometimes with a broken cusp, sometimes with just a broken occlusal, or even we can have a very broke down tooth. But then we analyze the tooth a lot more in detail, and we can be designing the preparation in different ways, trying to maintain the most enamel that we can, trying to maintain the most dentin that we can, and also utilizing materials with adhesive dentistry that we can bond to the existing structure, and we can reinforce the actual tooth structure as well. Then putting all ceramic restoration on top, and everything works as how the old tooth was working. So it's more like analyzing the tooth, each defect that the patient has, and deciding what type of is the best preparation for the patient.
Sure. There's a lot to be said when you're having a discussion with a patient and you're discussing a crown. There's almost this mentality that patients have in their mind of, if you're going to do a crown, that means you're just going to take this down to a small little nub, and that's all that's going to be left of my tooth, and it's going to have some issues to it afterwards. It's been amazing to me how many times I have to have that conversation with them of, actually, we don't have to take that much away from you anymore. We used to, but we don't have to anymore. So your traditional preps, you're trying to be conservative with things. You said that you're a little bit more on the passionate side of the technology base of how that can work for you, of being able to do these more conservative preparations and restorations. Tell me what your process is. If you've got, let's say, just a broken cusp off of a molar. You're not initially looking to be doing full coverage, or are you looking to do, say, a crown lay, or what is it you usually look for?
So, well, for me, yes, I obviously analyze the patient comprehensively. There's all the main issues in the mouth, but let's say if it's just a single tooth that I'm focusing on, yes, I focus on what the type of defect the patient has, and how did it fracture. So if the patient had a previous amalgam, that's a very common thing that happens. So the amalgam, since it's so rigid, sometimes it just fractures the cusp. If the patient has occlusal issues, then that's a different thing. But yes, I try to analyze where the fracture happened. Then I analyze how much of the remaining tooth structure there is. And hopefully, if I have lots of enamel remaining, I like to preserve that enamel as much as possible. That we know we can bond to that enamel very well, and also dentin, but we just have to be taking a few extra steps. And then basically, yes, so we just need the space, and that's usually I tell my students, we just need to prepare where we need the space for the ceramic material. So there are some areas of the patient, since it's already fractured, we barely have to touch it too, because the patient already gives us the space for the ceramic. So that's all the things that we have to analyze from the defect of the restoration.
As dumb as I am, I realized right after I asked the question that I just asked the prosthodontist how to work with a single tooth. It is so much more comprehensive. Yes. Let's talk about the materials that you actually use then, and what equipment do you actually use when you're doing these procedures. So are you still traditionally impressing these, or are you actually now doing full technology of scanning, or what is your process there?
Yeah, right now I think really the PBS, very rarely I'm doing it at this point. Really my only indication, I actually have to give a lecture to the students the other day, but really my only indication right now to do a PBS will be if I have a very deep margin that the scanner is not able to capture that data because it's subgingival. So right now, that will be my only use for normal polyvinyl siloxane. So the rest, yes, we're doing everything with digital impressions, milling, chairside, and also as much as we can when we have this type of restorations that is just replacing a cusp or just maybe even a crown, we're trying to prepare, impress, and deliver in that same appointment. So we just have everything now scheduled. If we're going to do that, then we have the patient for, now the technology got so fast that we can have the patient for about a couple hours. Sure. Patient comes and I do the very small preparation depending on the defect. We go ahead and take digital impression and then do the design, mainly the restoration, and the patient is probably going to be done within the next couple of hours. And for us and for the patient, I think that works very well. We don't have to worry about provisionals, patient coming back in a couple of weeks. Patients are more happy since taking everything done in just one appointment. So lots of advantages.
Makes a big difference. When I was in school, I remember it being about a 4-appointment process to do a single crown. Yeah, it was painful for them. It was painful for me. The whole situation was horrid. Can I ask what scanner you actually use?
So right now I have the Trios 5.
Okay.
That's the one that I personally have. Also, I have access to the Primescan from Dentsply Sirona, which also I just find out that they launched the new one. It's going to launch in Dentsply Sirona in a couple of weeks, but I saw the new update from the rep the other day. So that one is coming. Very interesting because we're used to have all the digital scanners connected to a laptop or to a computer. This one, the main difference with the Primescan 2 is going to be that everything is going to be cloud-based. So you're taking the digital scan. Obviously, you're still in a computer, but the main difference is that where you're scanning, all your scannings are already uploading into the cloud that is from Dentsply Sirona. So all your scans are going to be saved in the cloud. And also they have the design services that you want the AI to do design for you, or also you have the option to do it yourself as well. So that is very interesting. Yeah, but personally, I have the 305. I tried many in the market, and my orthodontist has the new iTero Lumina. Very cool. That has a disco light. So I think for kids and ortho cases, that's pretty cool. They get very excited when they see that amount of light. So yeah, I think I've used mostly in the market. Just to tell a quick story, but I started my pros program with 2014 with the first iTero that it was in the market. And that technology at that time was taking pictures. So instead of that, we do videos with the scanner, it was taking pictures. The scanner will tell you a scan buckle of number 2, then scan occlusal number 2, then scan palate number 2. So you have to start taking photos of almost each tooth. I think I still remember a scan top and bottom. It took me about 2 hours to get the full set of scan. Yes.
Oh, gosh.
I think
it's a little different now, isn't it?
Yes. So now, yeah, with any scan in Trios 5, any of those, you can take top and bottom scans within a couple of minutes. Now all the assistants, they can do the scans for us as well. So easy at this point. I really don't see any point why you shouldn't have a scanner in a practice right now.
The pieces of equipment in my office right now that I use more than anything else are my scanner and my intraoral camera. Those tell the story for me, where I don't have to try and explain to patients as to what's happening and why it's happening. And the efficiency that comes, the time improvements that come with it, the accuracy that comes with it, it's just astounding as to what we've actually gotten to. And the funny part with our industry is that we get better and better with it all the time. So what other pieces of equipment do you actually utilize and use in your office?
Yeah, so that's with the scanners. Also, we have the Primemill, also from Dentsply Sirona. With that, we have option to mill pretty much any all ceramic material, from glass ceramics, zirconia, any of the hybrid ceramics, PMMA restorations, all that we have access to mill with the Primemill. And also we have a couple of 3D printers as well. So then we have the option to, in some cases that we like to do something with additive technology, like 3D printing, especially with printing like all on X type of prototypes. Sure. With that, we do a lot of the printing, very quick provisionals that we need within the next 5 or 10 minutes. Also, we do the 3D printing. Very interesting resins that they're in the market right now. They have ceramic part fillers in the resin. So now we have very strong resins that we can manufacturers that you can use as a final restorations. Right now, we don't have the studies to really back that, but usually I tell my patients it's more like a mid-term type of prototype. So I tell the patient, yeah, this is going to last maybe, 2 or 3 years. And then in that meantime, obviously, we'll be thinking to move it something more like ceramic wise down the road.
Sure.
Yeah. I mean, there's so many different materials that we have access now that sometimes it gets overwhelmed, the amount of especially all ceramic and the new resins. Yeah. People get very confused about these materials, but yeah, very excited.
There's too many of them out there for us to choose from. And normally I would ask, so what is it you use for your restorations? But it's very case dependent. If you are playing in these games of conservative dentistry, it's not a one size fits all. It's not a cookie cutter situation to it. You have to go through. And again, I'm even going to step back one more time to say that I even apologize for even asking about the single tooth, because you can't. There is so much that goes in to how you actually treat a single tooth. It's the same if you're doing a full mouth rehabilitation, just like you were talking about beforehand as well. But do you have a certain thing that you look for to say this particular tooth might need zirconia, this one might need a lithium disilicate, this one might need a PMMA, this one might need to be in temps for a little while? Is there a certain item that you kind of look at and say, this is what I need in this particular situation? Or is it just truly customized to each person?
That's a good question. That's where it comes down to, obviously, the comprehensive evaluation of the patient. I know that patients, there are already signs of ruptures. Those are really just a headache. Even after we finish the rehabs, those are super difficult to handle.
Sure.
But those are the ones that when I need really the most strength that I can from the material, that's when I might choose a zirconia-based type of material.
Okay.
But if I have a case that is more the etiology from erosion, that we know as last month we take care of the erosion with the physician, usually the risk of those patients is actually pretty low because as long as you take care of the erosion. So those are cases that they're great for glass ceramics, especially if I have lots of tooth remaining. We know that we can bond glass ceramics very well to enamel and dentin. Zirconia, you can bond as well. Now we have some research that really backs up that we can bond zirconia. Sure. But then you have to take a little bit different steps. And also, very interesting with coming back to the technology that now we have glass ceramics that they can be milled within, I don't know, maybe 6 to 8 minutes in those blocks. And a lot of them, they don't even have to be crystallized anymore, like a normal Emax that we have to mill it. And then we have to do a crystallization process that takes about 18, 20 minutes. So now those you can mill and just basically hand polish, or you can also stain them if you want. But then for me to mill only or any very small restoration, I can have a restoration ready within the next 15, 20 minutes. So really, I love it. It's just amazing that we can have that amount of time and a very aesthetic restoration as well.
And like I said before, and to have that be what the experience is for the patients now compared to what they've experienced in the past, for you to actually say, I can have this done in about 10 minutes, polished, ready to go. We'll bond it into place. You'll be on your way in just a few minutes. They kind of look at you like, no, there's no way that's possible. Yep. Watch me.
It is possible.
We're going to do it for you. It's going to happen. Absolutely love it. I want to transition you for just a moment, if you don't mind. You said another one of your passions right now is adhesive dentistry. Tell me a little bit about why it is that adhesive dentistry is one of your key topics right now.
Again, I guess I was pretty lucky that I finished my pros program. Again, very traditional type of normal prosthodontics. And then I was very lucky when I was at Alabama. Dr. Ed McLaren came to Alabama aesthetics and also a ceramics program. So I was lucky that I started working with him, and then just watching him work, and then he's telling me like, no, for this case, we're gonna be able to do just a partial veneer. And he told me, I'm like, a partial veneer. I know a veneer.
This doesn't make
sense.
Veneer,
but I'm like, a partial veneer. And he said, yeah, basically it's just half of the veneer. And I'm like, okay, yeah, that makes sense. But then like, how is he gonna hold? And then I just watch him do the whole thing. And then at the end that he finished everything, I'm like, that makes total sense. Like, why do I need to prep more of the tooth? And I'm just replacing like half of the tooth. So that is just one example with Ed McLaren. But then obviously, we started. Also, I work with Dr. Nate Lawson, where he does a lot of the bonding for materials research. And then, in the lab, he's showing me, like, look at the bond strength that we can get to enamel. Look at this bond strength that we can get to dentin. And then there's really no reason why you should be bonded in material because you get so much of a bonding strength to the tooth. That combined it with the materials that we have available that we know that we can bond it very well, then that's when we know that we can be very conservative instead of just trying to remove half of the tooth to get a stronger material in the mouth. We can just keep as much as we can, bond that restoration to the tooth, which is actually now the newer studies and showing that sometimes it even makes the tooth stronger. Then that's really the advantage of using adhesive dentistry with all ceramic materials.
I love it. So is there a certain process that you do? I assume you're still etching. I mean, it depends on the material that you're using with it. But for me, I've gotten it to a position where I've done this long enough with my assistants that I don't even have to ask for things anymore. I just put my hand out and it's the right thing that's coming into my hand each time, which I love. Is there a certain process that you like, certain way that you do things in a fairly generic form for those that are listening, of just things to be looking for to enhance their adhesive dentistry?
Yeah, so right now, very interesting. Obviously, the universal adhesives, they changed quite a bit how we're doing things. So again, I was trained with the normal 4th-generation adhesive. You had to do the 3 steps, the etch, prime, and bond, which, I mean, they work very well, but it took too many steps using those adhesives. Now with universals, they changed a lot of how we do things. Graping for a normal bonding procedure, then I know that's debatable or not, if you want to use the rubber dam or not. For me, I mean, I hate placing rubber dams, but usually, I don't know, I use rubber dams, but I hate placing them. The great thing is that, yes, I found an assistant that is expanding functions and she knows how to place rubber dams very well. So that
Well played.
really, yeah, complete change, because I know that she can place the rubber dam for me. And I think for me also, a main reason that I place rubber dam is that the patient cannot really talk. So then the patient cannot
Which is
talk.
better by itself.
So I know I can focus in my procedure a lot more calm and closer.
Sure.
So for me, yes, a rubber dam, yes, I used it. If you don't like them, yeah, I mean, just get an assistant to place it for you. But yeah, so we know the studies, the newer studies with the universal adhesives, they cannot etch enamel the same as a normal phosphoric acid. So if you have any enamel surface remaining on the tooth, we still recommend to do a selective etch pattern. So you take the phosphoric acid and just do etch of the enamel. With dentin, newer studies are showing that we can get bond strength very similar to the old adhesives, just using it in a self-etch mode. So basically, we just apply the adhesive on the dentin. So that's basically with the dentin and enamel. Also, another thing that we have been using, that we did a few studies also back in Alabama, is the use of vibration device, intraoral vibration device.
Yes.
So that has been since the 80s that we sample as materials. But now the main difference is a couple of different devices is that they combine the aluminum oxide with water. So then we can do aeration of the tooth structure very nicely with aluminum oxide and water. And that, it's for me still the best way that you can clean any temporary cement remaining, any biofilm on the tooth before you start your bonding procedure. So that is a very great device that I use all the time now.
Yeah.
And also now they send particles you can use for silk or any different particles that you can use for like heavy prophies and anything like that. So now there's a lot more uses for the device. But yeah, so now I try to always, if I isolate the tooth, I go ahead and do aeration of the tooth structure. Then I go ahead and do selective etch of the enamel, self-etch on dentin. And then that, if I'm doing a total, we use conventional resin cement. Also now that is going to change, or it's changing a little bit now that we have very good self-adhesive resin cements as well. So then we don't have to focus too much on treating tooth structure. And that they're showing a lot of the bond strength as well. So that is also changing a little bit with the self-adhesive resin cements.
I love it.
I don't know if I went a little bit deeper with the...
No, that's perfect. No, don't you dare. That's absolutely fantastic. The inclusion of air abrasion into my practice was one of the greatest enhancements that I've actually done. And to see how much better things hold, see how much cleaner things can actually be, it's a little bit too easy for us as clinicians just to try and get the patient out as fast as we possibly can. Not a prosthodontist. I don't think I would ever hear somebody like that or something like that out of a guy like you. But even still, there's a lot to be said of taking those extra moments. I mean, we're not talking a long period of time to abrade something like this, nor are we really talking a lot of time to actually place rubber dam, but we'll leave that one alone for you as well anyway. But when it comes to it, if you, I'll say this, from Dental Advisor, we notice that there's a great lacking in reading the instructions on the materials that you actually utilize and use. If you actually have a very nice, clean environment, then all of these materials should work out for you fantastically. But if you don't, then you're cutting steps out. And I think at some point you're going to have some issues with it. Well, Celin, is there anything else that you've actually would like to add to any of this at all.
That, and I think another great thing that I'm been using for going back to the technology, once I finish my cases, especially the full mouth rehabs or even like a normal type of restorations, I think a great way that we can monitor that usually we finish the rehab or the restorations, and we like to take like a post-op intraoral scan of the patient. And then there are some different softwares that sometimes they come with the scanner. They have the monitor of the patient. So if you see, let's say that's your baseline, after you finish your restoration, you take that post-op scan, then you see the patient 6 months after that or a year after that, and then an assistant can take a follow-up scan. And now we have softwares that they can really start comparing those intraoral scans as a follow-ups and see if you're already looking at some changes in the tooth structure as well. Especially for the Broxer patients, it helps a lot to see if really something's happening to occlusion after we finish. Erosion cases as well. If we start seeing clinical signs that the patient has a relapse coming back to the erosion. So now we can even measure changes in the tooth structure changes over time. We're using the intraoral scans as well. And now also they're using that for a lot of the studies to measure accuracy of materials and all that. So that's how we really start measuring. Now we can actually get data measuring how much of the changes the patient is having.
Sure. You know, I'm going to ask, can you tell me what software it is that you use to do those comparisons?
So their trios, 3Shape Trios has a 3Shape Unite. It comes with different features as well. Okay. But one of them has the monitor. It's called, Monitor Review. So then also that is also saved in the cloud. So let's say you take your scan post-ops that uploads in the cloud, and you see a patient a year after that, you upload it into the cloud. And then the software itself is already superimposing the images to see if there's any changes. So 3Shape Unite, that it has that feature. And also recently they came out with very cool features as well using AI. That also, I think that's going to change pretty much everything how we do in dentistry as well.
Absolutely.
Now, obviously, that's like a whole different topic, but the new softwares now, they can give you measurements from the CAJ to bone levels. It already tells you the patient has bone loss. But especially with 3Shape, and there's others in the market, they have the option to give you AI design occlusal appliances, AI night guards. So basically, you upload the 2 STLs of the patient, and then you'll get a night guard design. The last one that I did, I got it about 45 seconds around when I uploaded the files. So in 45 seconds, I got that file to review, and then you can make changes if you want. But it's not that someone is designing, I don't know, in Australia or something. No, that it's uploaded into the cloud. AI designs it for you, and you download it. And then it will be ready to send to the printer as well. So that's also kind of changed that now we can even give occlusal appliances pretty much chairside to the patient. So in the past, I used to take impressions and send it to a lab. Then I get an IGR back, 2 weeks after that. Now we can even give this out pretty much like the same day to the patient. So that's going to change a lot. They're also having AI crown designs as well. So you finish your prep. In case you don't want to do the design by yourself, you upload the files and you get a crown design. Then you can send it to the printer or to your mill, depending on what technology you have. But yeah, definitely AI is going to be changing everything that we do, and pretty much anything in dentistry.
And from what we can tell, in very good ways, more efficient ways and everything else, like we said beforehand. That's a topic you and I might need to revisit at some point, because that could take us another 45 minutes to even just discuss that type of thing. Yeah. Celin, thank you very much for spending a little bit of some time with us. As we've been talking about this, I really and truly, I am always back to trying to allow for clinicians to build some confidence in themselves. And in discussing these things with you, I've realized that you can only be as confident in your own procedures as you are with the materials and the equipment that you actually have. If you have no confidence in those materials that you're using, it's hard to believe in what you're actually doing and what your confidence level is in your procedures. So you've made me kind of relook at things a little bit, so thank you for that. And for those that are listening in, if you're trying to find certain materials to trust, different things like that, then you can always go to the Dental Advisor website, dentaladvisor.com, and take a look at some of the evaluations that we've done and see if there are some certain materials that you could start looking into to start building that confidence as well. Celin, once again, thank you very much for joining
Thank
me.
you so much for having me.
And for those who are listening in, we'll catch you the next time through.